Hello, everyone. So it's nearly 3 years ago that we were in this very hall when we were talking about developing a new mother and baby unit and perinatal services in Lancashire and Cumbria. And it's amazing that we've moved on from then, and I'll fill you in a little bit more detail as we go through the presentation. It's AN, like Gordon Strachen. No relation, though. Am I pushing the clicker wrong? Oops. Okay, so we're going to talk a bit about perinatal mental health, a bit about the national drivers, the links between maternity drivers and also mental health drivers, what's happening locally, and a sort of linking into reminding with a couple of patient stories as to why we do what we do and what led to the drivers. So the stories can be a bit hard to hear, so just to bear that in mind. So if we think about the scale of mental illness, mental ill health in pregnancy and the year after women have had a baby, up to 25% of women will experience anxiety or depression or some other mental health problem during pregnancy and in the postnatal period. So anxiety and depression are as common in pregnancy as they are in the postnatal period. So this is not just about postnatal depression, this is about depression and anxiety during pregnancy. And when we work with women in the postnatal period and we ask about the onset of their symptoms, we often find that they were there in pregnancy and it was hard for them to talk about them. But if we can find out about them and do something about them, then we know that that has better outcomes for both mum and for baby. So if a mum has a mental health problem, then that can interfere with her ability to parent. It can interfere with her confidence in parenting. And that interference in her ability to parent and to develop an emotional bond and reciprocal relationship with her child can have lifelong consequences for the child. So we know that mental illness can have an impact on the emotional, the behavioural and the cognitive development of the child. And that can have life-lasting consequences. And if a mum has perinatal mental health problems, then her daughter is more likely to have perinatal mental health problems. So there's an intergenerational effect. So this is about getting in, detecting, treating early and improving outcomes, not just for that mum, but for her child and for the rest of her family. So when they looked and mapped and rated what perinatal mental health services there were nationally, they found that there were areas in the country that had no services at all. Some areas had a mother and baby unit and community services, and they were green on the map, but areas like us, unfortunately, were red, so that was that we had no perinatal mental health services. So 5-year forward view was about making sure that nationally there was improved access for 30,000 women annually to specialist perinatal mental health services so that we could have an impact on those illnesses. So to tell you about when 3 years ago the map was red here, there was nothing. This is the mother and baby unit that opened last week at Chorley. So it's the Cumbria and Lancashire mother and baby unit. So we admit women with severe mental illness from 32 weeks gestation up to 12 months postnatally. So it's a homelier unit than an acute mental health ward might typically, you might imagine. We have 8 beds, 8 ensuite bedrooms. We have a multidisciplinary team with nursery nurses. Health visitors are going to be coming in to do a sort of well baby clinic to try and keep things as normal as possible. We have a psychologist, an occupational therapist, a social worker, as well as psychiatry and mental health nurses, and outreach workers that will support mums into and out of the unit. So the bedrooms are quite spacious and friendly. And alongside that, what is underway now is the development of specialist community perinatal mental health services. So these will work with the 5% of women that have the more severe end, not the mild to moderate end. and that is for Lancashire and South Cumbria. So recruitment at this stage, we have the service manager, we have the team leader, we have one of our psychologists, and we have recruited, although they're not in place yet, mental health practitioners. There's going to be nursery nurses in that team as well, so they'll be working with mums in the community, supporting them, supporting their parenting as well as treating their mental illness. And that's what one of the bedrooms look like. So these blankets are from the Linus Trust. So when a child is admitted to an inpatient facility, the Linus Trust has crafted blankets that's then the mum and the child, and they get to take them home with them. So we have that in the unit. And that's what the bedrooms look like. Okay, so if we're thinking about what Better Births says, because you know there's a chapter in Better Births about mental health. What does it say about mental health? What should be maternity services be doing about mental health? One of the key messages, of course, is that mental well-being is as important as physical health. And we need to be as vigorously looking for mental illness and treating it the same way that we would with physical health problems. Because we know that mental illness not only has an impact on the mum psychologically, it has an effect on her pregnancy. So we know that if mum is stressed and anxious in pregnancy, and depression can be a cause of stress and anxiety, that crosses the placenta. The hormones that are involved in that cross the placenta. The fetus is affected by mum's stress. And if mums are stressed and anxious and depressed in pregnancy, then the infant is more likely to develop depressive disorders, anxiety disorders. It's more likely to have behavioural problems, and there's even flags that there are physical consequences. So infants are more likely to be mixed-handed, they're more likely to have immunological illnesses, the telomere length at the end of their chromosomes is shortened. So there's a physical consequence to the fetus of untreated mental illness in pregnancy. So this is a picture that I got off the internet, which was indicating that pregnancy isn't a marvellous, glowing time for lots of people. But you'll notice that it doesn't mention it's not coming on. Oops. Depression and anxiety. So as I said, up to 20% of women suffer from depression and anxiety in pregnancy, and they might be reluctant to talk about that because of the expectation that pregnancy is a time when you should be particularly happy, planning this wonderful event that's coming to you via a stalk or whatever. But major depressive illness is the commonest health problem related to pregnancy. And we know that, as I mentioned, you're more likely to have problems in the postnatal period if you've had problems with your mental health during pregnancy. And there are other factors related to pregnancy that can make you more likely to develop a mental illness in the postpartum period. So traumatic delivery, and that's not necessarily always what a midwife perceives as a traumatic delivery. So a midwife might not think that that delivery was traumatic, it was maybe not instrumental, but mums experience trauma in a different way. So if I've heard mums talking about how they were given, they had an analgesic, it was maybe an opiate, and that affected their memory, and so they weren't aware fully of what was going on, and that loss of control that was associated with that meant for them their perception of that was as a traumatic event where they didn't know what was happening. So if we don't ask about their perception of how their labour and delivery was, then we might not realise that they experienced it as traumatising when it was a fairly straightforward delivery. And we know that if it is what we consider an obstetrically difficult delivery, then there is an increased risk of more severe mental illness such as postpartum psychosis and a severe depressive episode. And if you think about if a mum has to have an emergency section under general anaesthetic, then you can see how that could impair on mum then bonding with her baby because she wasn't conscious and aware when baby was born. It might lead to a delay to her having skin-to-skin contact with baby, and that can interfere with mum's relationship with her baby. So we know that NICE has said for a long time that these are the quality standards, and these are what maternity services are doing, are asking in pregnancy about a history of severe mental illness, and then asking at every contact about their emotional well-being, so that we can pick things up early. So the earlier we pick things up, then the interventions that are needed earlier might be less. So it might be self-help if it's picked up earlier, or it might be a referral into IAPT. So IAPT have undertaken to prioritise women in the perinatal period. So they have undertaken, as per NICE guidance, to assess women within 2 weeks and to treat within 6 weeks. So if we can pick it up earlier and the interventions can be at a lower level, then that's helpful for the mum, for the family, and for health services as well. And this is why we need to do this. So this study looked at perinatal depression, and of 100 women, when they surveyed women retrospectively, only 40 of those women's illness was clinically recognised. Only 24% received any treatment at all, and only 10% received inadequate treatment. So there's a lot of illness that we were missing and not being able to do anything about. So the Embrace, was just the most recent, was just launched last week. And again, it's reinforcing that there's, we have a clear duty not only to ask about mental health problems, but to make sure we're asking the GP if there's a history of mental health problems, because there is still a stigma about mental illness, and sometimes mums might not appreciate the significance of their previous admission to a psychiatric ward. And they might not want to talk about it. So we need to make sure that we're inquiring of GPs if there's a mental health history, that GPs let us know if there's a mental health history, and that if a woman is involved with mental health services, that there's good communication between mental health services and maternity services. And this is one of the reasons why we need to do that. So this is Daksha Emson, who was a psychiatrist training at the same time as me. I was in Glasgow, she was in London. She developed severe depression when she was a medical student and had an admission and needed treatment with ECT, actually. She then had a manic episode as a junior doctor and was re-diagnosed with bipolar affective disorder. And she was stabilised on lithium as a medication for her illness. She met her husband during that time. She was under the care of a psychiatrist in the community, but didn't want care coordinator because she lived near where she worked. She came off lithium as she wanted to start her family. The psychiatrist retired. She had a new psychiatrist, and she developed depressive symptoms in the weeks and months after she had her baby daughter Freya. But this seems to have developed and worsened very rapidly into a psychotic depression and a relapse of her bipolar depression. And her husband came home one day to find that Daksha had stabbed baby Freya and poured accelerant on them both and set fire to them. So baby Freya died, and Daksha died 2 weeks later without regaining consciousness in ITU. Now we know about this tendency for bipolar, particularly to recur in the postnatal period, but there wasn't a robust plan in place, and there wasn't good communication between maternity, GP and psychiatry. And part of the inquiry into Daksha and Freya's death was, well, what do we do about that? How do we tighten up our communications to make sure this doesn't happen again? How do we make sure there's a robust plan in place? And part of that is about having a really good mental health maternity birth plan, so that it addresses not just the obstetric issues, not just where she's going to deliver, but who's going to be checking the mental health before they go home, who's going to be checking their mental health when they're in the community, who's and linking in an overlap with midwifery and health visiting that's maybe longer than in standard cases, and getting mental health in there as well, so people know who to phone as soon as there's any signs of relapse. So when we're asking about history of mental health, or if we're asking about how women are currently, it's how we do that as well. So not everyone who has a mental illness looks like this. So some manic people do present like this, but Daksha was almost a consultant psychiatrist when she was pregnant. And some of the other cases that we know about were, the women who die from suicide in the postnatal period are more likely to be professional, married, own their own homes, university educated. So you cannot tell by how someone looks. If they've got their makeup on, if they're well dressed, that doesn't mean they don't have a history of a severe mental illness or are currently suffering with anxiety or depression. And when I see women referred to the clinic, sometimes from midwives in the liaison clinic, this is some of the things that midwives have written in the referral. So the woman admitted to a history of depression. Now, if you put diabetes in there or epilepsy, you would never say that a woman admitted to a history of or disclosed a history of. So it's something about how we think about it, and some of the language that we sometimes use helps to keep that stigma going and make it sound as though there's something shameful about it. But remember, this is 20% of women. Or sometimes women have told me afterwards that when we say, well, were you asked about your mental health earlier on? Well, they said, well, I'm sure this won't apply to you, or I've got to ask you this, but I don't think it'll be you. Or some women who are mental health nurses have told me that they were said, oh, well, you'll know all about this because it won't be you. So they weren't asked in a way that encouraged people to talk about their mental difficulties. Now, sometimes that is because, well, you might be frightened of opening up a can of worms and not knowing what to do with when a woman tells you about her past history or how she's feeling now. So in Blackpool, health visitors are now asking mums about any adverse childhood experiences. So not just about history of mental health problems and not just about what you're feeling now, but if a mum has any of these adverse childhood experiences, because we know the more of these you have, the more likely you are to have a mental health problem. And in fact, if you've got 4 or more, you're more likely to develop physical health problems in adulthood as well. So, and it's asking women, giving them the opportunity to reveal any of these problems. So if a woman has a history of childhood sexual abuse, then pregnancy and labour can be a really triggering time that can precipitate a woman into a relapse. So Better Burses also talks about women being able to, so you've opened that can of worms, you found about the history or you found about their present problems and what we're going to do. So we need to refer in a timely way. So as I've said, IAPT will see women, will prioritise women. Secondary mental health services, we're working with them to lower the threshold. So to work with women like Daksha who are currently well, who don't meet criteria. And when the community perinatal service develops, then those are the women that we will be working with. And it's making sure there's links for the women who've got milder problems, making sure they can access that. So we know locally what there is. We know what the sector organisations there are. We know what mother and baby groups there are. And we can also link to online resources, the social media self-help groups that women can link it to. And often women sort of watch what's going on in the social media groups for a while, and then they engage with them as they get more comfortable with them. So part of embedding this within maternity services and joining up with mental health, the North West Coast Perinatal Strategic Clinical Network has one of the subgroups is led by our specialist perinatal mental health midwives. So all the maternity units in Lancashire and South Cumbria have specialist perinatal mental health midwives, and they've developed pathways for midwives and health visitors so that they know the sorts of questions that they can ask, they know the sorts of rating scales, and then they know that combining that with your impression of the woman, you know that you should be signposting this woman or recommending she refers to IAPT or referring into secondary mental health services. Just embrace again the new report, just to think about, so we and remind you that suicide is a leading cause of death in the perinatal period. And to remind everyone of the red flags in the postnatal year. So we know that these are particularly significant, and these are the sorts of things that we would like community midwives and health visitors to be aware of and ask about when they have contact with women in that postnatal year. Because we know that these were themes that are common in this women who die by suicide in the year after they've had a baby. But this new report also has talked about amber flags. So this history of a past psychotic disorder, and then closely monitoring women with a history or a family history of bipolar disorder or postpartum psychosis. So you know that for women in general, the risk of a postpartum psychosis, which is a severe psychiatric illness, it's a psychiatric emergency, is 1 in 500 deliveries. If you've had a previous postpartum psychosis, your risk is 1 in 2. You have a 50-50 chance in subsequent pregnancies. And if you have bipolar disorder, your risk is 1 in 3 or 4 of developing a postpartum psychosis. And if your mum had a postpartum psychosis, that risk is increased, and they're cumulative. So that's why we ask, that's why we need to know. And this is Charlotte Bevan. So she had schizoaffective disorder, which is very similar to bipolar disorder. She had a care coordinator under a community mental health team, and in pregnancy she discontinued her risperidone medicine, which is an antipsychotic, because she didn't want her baby exposed to that. She delivered her baby in an obstetric-led maternity unit. She worsened quite quickly again in this postnatal period. There wasn't a robust plan in place. And she left the ward with her baby, and they jumped off Bristol Gorge and died. And again, the coroner was scathing of the planning, the care planning, and the lack of community perinatal mental health services. And she lived and had her baby minutes from a mother and baby unit, but they hadn't been involved in the planning. And this is, I just thought I would highlight again in the most recent Embrace report is something about lack of engagement, so disengagement. So difficult to reach women or women who disengage, then we need to try and find out why that is, because that might be because they're getting more unwell. And they might have a fear that they're getting more unwell, and that means people might inform social services and their baby will be taken away. Women are always telling us that's part of the reason why they don't talk about their mental illness if they're not asked, why they don't talk about this feeling they have of not being a good mum. It's because they fear that means they'll be referred to social services, and social services will agree that they're not a good mum and take their baby away. So, as well as this development of specialist perinatal mental health services and the mother and baby unit that are dealing with the top end of illness, then what else do we need to think about to make sure that there's a fully integrated pathway that links up for all levels of mental illness and distress? And the community hubs are perhaps an ideal opportunity to make sure that we're linking into what is in each area. Because what we've found as we've been developing services across Lancashire and Cumbria is there's things happening that we didn't really know about. So if we don't know about them, we can't link into them and we can't signpost women to them. For example, Mind in South Cumbria has been running some postnatal depression groups that we weren't aware of when we were thinking about our pathways and links. East Lancs is having in-reach into some of the neonatal unit to support mums there. Okay, I've got to the end now, I think.
There's can you just explain just one thing that's come through Slido is IAPT. Not everybody in the audience understands IAPT.
So IAPT is Improving Access to Psychological Therapies. That's what it's called nationally. And in different areas, it's called different things. So in most of Lancashire, it's called Minds Matters. In Blackpool, it's Supporting Minds. I'm not sure what it is in South Cumbria. First Steps. So the IAPT services are commissioned differently in different areas, and there are sort of a tier of services that they will do CBT with mums, they do some groups, they have health and wellbeing practitioners that look at resilience or different ways of coping or anxiety management. That's the sort of work that they do.
And just one other question on here before we ask if there's anything from the floor around at what point are ACEs discussed with women and families? Is that antenatal or postnatally? And can we capture this sooner, i.e. preconceptionally?
Yes, so I think that the as part of the, I don't say better births, not better births, better start in Blackpool. Then the health visitors, I think they're asking at the preconception.
It's an ambition across the ICS to be absolutely ACE aware. We discussed it again at Lancashire Safeguarding Board this Wednesday, but for all services to be ACE aware and be asking at any point in anybody's lives, isn't it, in terms of what that is for a whole host of reasons. And
it's difficult to ask about to start with. And you need to have be more confident and more used to asking, so it becomes normal and part of your sort of inquiry.
Sorry, Jo, I was just going to say they also do the health visitors within the Blackburn area, the unitary authority there, are also undertaking ACEs. They ask from the antenatal through, and we're also comparing it against children's development.
Yeah.
So we're actually collecting data over a 2-year period to see what the effect is of the ACEs on those children, as well as making sure that they get the right services.
Yeah, because what asking about ACEs can lead to conversations about how do you think that affected you as a child? How do you think that's affected you now? What might have made a difference? How can we make it different for your child? Because mums want to make it better for their children. And so that can lead to conversations and signposting of ways to help mums make their children's childhoods better than theirs was.
Just building on the ACEs conversation, I think there is a bit of momentum growing within Lancashire. All the councils, the police and the NHS are really keen on taking forward, having Lancashire and South Cumbria as an ACE-informed county, if you like. So getting all of our frontline practitioners trained up and being aware of ACEs and being able to ask the right questions. So I'm just working on a proposal with other colleagues of how we roll that out and develop that. There's some great practice already happening. And so it's not about reinventing things, but it's about making sure that all areas are embracing that approach.
Hi, again from neonatal perspective, and it was really great to see clearly in your presentation the word neonatal, because we know that we've had huge amount of support across the neonatal network from North West Coast and now Greater Manchester perinatal networks and the SCNs regarding recognising neonatal staff as frontline, so that the mums that experience a neonatal journey all experience a trauma. Entering a neonatal unit is a trauma. And we are running with lots of support from clinical psychologists and led by neonatal parents, 2 perinatal mental health study days specifically for neonatal staff to help them to understand their role. Not only, we don't want any neonatal staff diagnosing mental health, what we want to understand is that change of culture to support every parent that experiences a neonatal journey. And I think they probably are those ones that are red flags that perhaps disengage from services from a maternity point of view.
Yes.
They only want to be on a neonatal unit next to their baby. So they say, I feel fine. And actually they are the ones that on discharge from a neonatal unit very often are diagnosed with more severe mental health concerns. And we really feel that neonatal staff can be that front line to support them. So thank you for the support that you've offered us with that as well.
From a service user's perspective, I'm interested in it's a genuine question, it's not a challenge. How do you manage the difference between choice and disengagement? Because I could imagine a situation where a family, a mother, would choose to not go down a path that maybe clinicians and others would consider the right way, and that's from a position of informed choice and for reasons pertinent to the mother. And you may interpret that or may choose to interpret that as disengagement that might be interpreted as a mental health crisis brewing. And I'd be just really interested to understand how that would be managed, please.
I think it's a flag that disengagement might be a sign that a woman is getting more unwell. So it's about trying to make sure someone has got a therapeutic relationship with the woman or her family so that you can inquire sensitively. You're absolutely right. People have a choice whether to engage or not, but what we don't want to do is miss someone who has disengaged because they're becoming more and more unwell, and getting to the stage that they have to have some compulsory help. So we want to get in before that, really. So it's about forming therapeutic relationships with the woman and her family.
Just to follow on from that, which is what you raised before, which is continuity of carer. So continuity of carer will absolutely address this issue.
Yeah.
And that is one of the benefits of it.
Just really on a positive note, I've worked in this area for over 22 years now. Yeah. And in the past, it's just awful because you had women in your clinic who clearly had mental health problems. There was absolutely nothing you could do about it. There were no services. The change, I think the alien in looking at mental health services would see a difference at how there is. I mean, we still got a way to go, but just on a positive note, in my clinic now, if I spot a problem, I've both been given the tools to spot them, having as an obstetrician never been taught anything in medical school, or doing my training as an obstetrician about perinatal. I hope the latter's changing. But really, the services that there are now are such a massive improvement to what there was.
Thanks. And it's also known, although we know that stress and anxiety is harmful, we know that even just giving mums simple advice, we know that also if mums do 10 minutes of relaxation a day, so whether that's listening to music or reading or crocheting, then that helps to mitigate the effects of the stress and anxiety on the fetus. So it's not all negative. If you find it, then you can advise women on what to do to help to make it better. And you can do that in the clinic there and then. So you can give a positive message.
Hi, I just want to offer something really positive and celebratory about the mental health support that some women have had in our area. We run our communication training day, and we end with a film of a mum who tells of her experience in pregnancy of really having very serious problems. And she gives an example of how the team around her supported her so magnificently right from the moment where she was put in touch with the mental health midwife. People on the workshop sometimes comment, she's an articulate, intelligent young woman, but we explain that actually that isn't how she was at the beginning of her pregnancy, and it was only from the support from the wider team, a very large team of people, I think, that supported her, that enabled her to, sort of be supported through her whole pregnancy and the birth that she wanted, and afterwards, the follow-up afterwards, to ensure that she was still well. And we recently had an MVP meeting to focus on mental health in Morecambe Bay area. We had a really fantastic turnout of women coming along to sort of share their experiences, and more than one of them said, that the mental health support that they'd had saved their lives. And it was just really touching to hear that. And I just wanted to add that because of the distressing examples you've gave us of how drastic and distressing it can be when it doesn't get picked up and goes wrong. So, you really do make a fantastic difference when everybody is on the alert and responding. One of the main things that the woman said that we filmed was how she felt everybody was non-judgmental and really listened to her, and that enabled her to be completely honest. And that's how she got the care that she needed, because there was that trust there.
Yeah, that's great. Thank you for that.
Thanks, Mel. I think that's a really positive note to finish that session on. So thank you very much, Gill.